So when we see these cases of degenerative cervical myelopathy, although there are multiple classifications which have been described, but in real scenarios, there's a wide spectrum of patients that we see, ranging from mild multi-level small disc bulges to significant or advanced stages like OPLLs and instability. So there's a large spectrum of cases which needs to be managed, and there's a lot of confusion in managing these cases, and each case has to be individualized. So the debate of anterior versus posterior, as we have seen from morning, is a totally different debate altogether. But what we know now is that in posterior approach, when we do decide to go in for that, the indications are more or less clear. More than 3 levels is a standard indications, 3 or more than 3 levels. Yes, you do need a lordotic spine or a neutral alignment, and the level which has been defined is anything which is more than 13 degrees, less than 13 degrees of cervical kyphosis is an indication in multi-level cases. And the options that we have are laminoplasty, laminectomy, and associated and along with fusion, and where the idea is basically to increase the canal diameter. So having said that, each case, as I said, has to be individualized. You need to take into consideration the clinico-radiological picture of the patient. The functional assessment of the patient is very important. The presence or absence of neck pain before you actually decide a management is of extreme importance. So there's a support and there's literature on both sides for and against for all these procedures. However, overall the literature for laminectomy alone is slightly less as compared to the other two procedures. So laminoplasty basically is a non-fusion posterior decompression procedure where you have the best of both the worlds. You can retain the motion as well as give decompression, which is not the case in cases where you do a fusion. So as I said, the indications are more than 3 levels of myelopathic levels. The prerequisite that the patient should have a lordotic canal so that the cord can fall back sufficiently after doing a good posterior decompression, and minimal or no neck pain because you are sort of dealing with the posterior cervical muscles which form an important tension band. So the basic rationale is you need to, when you do a laminoplasty, you are basically expanding the canal, allowing for indirect decompression of the cord as opposed to the anterior surgeries or a laminectomy where you're doing a direct decompression of the cord. The advantage is you preserve the posterior tension band, the muscles, the ligaments, especially on the C2 spinous process, and you also maintain the normal dural cover, which is so very important, and this is especially seen in revision cases where we do a laminectomy and there's a thick post-laminectomy membrane. So safer revision surgeries are much safer in these cases. It also avoids post-laminectomy kyphosis, which is usually seen over a period of time when you do extensive laminectomies ranging from C2 down to C7. It reduces the muscle trauma, and possibly there's a possibility of reducing the neck pain because you're keeping all the musculature intact posteriorly. Again, hardware related complications as is seen in fusion surgeries can be avoided in most of these cases. So the outcomes are more or less comparable, and in some cases, some studies, they are much superior to other two procedures, that is laminectomy and fusion surgeries. However, there are certain predictors in laminectomy. One is the post-op kyphosis. So patients who have got reasons which are outside the lumbar spine, for example, the patient has got a grossly mismatched pelvic incidence to lumbar lordosis ratio, they are more prone to develop post-operative kyphosis. Axial neck pain, then sudden significant offset of the C2 to C7 SVA is associated with significant neck pain, and as discussed in the previous cases, significant cord intensity changes are a big hindrance for neuro recovery in cases where the patient does land up with a neurological involvement. So what are the techniques? So there are multiple techniques which are described. Again, there are two basic techniques, the open door and the French door. So in the open door, basically we create troughs on both the sides. On one side, it is a trough which goes through the entire lamina at the junction of facet and the lamina. And on the other side, it is just a trough in the superficial cortex. So the deeper cortex serves as a hinge on which we open the laminoplasty. Here you can see that it's important not to fracture the deeper cortex, otherwise the patient can land up with significant deficit. And hence these techniques are relatively more demanding as compared to laminectomy cases. The French door is again more technically demanding than the open door, where we split the spinous process in the middle, open them up. Again, on both the sides, you create a trough, which is only on the superficial cortex at the junction of the facet and the lamina, and you open up the spinous process and you insert a graft. So this basically expands the central canal. However, the lateral recess remains untackled, and hence these cases are not an ideal indication in cases where the patient has got a radicular symptoms or nerve root deficits. And probably you need to look at other options. So these are the two basic types. There are multiple techniques which have been described, but then again, these are technically demanding procedures, so usually not advocated. There are variations in these two techniques where you can open the doors and then you can add a graft or an instrument depending on what sort of surgery that you are doing. And now the focus and the pendulum is gradually swinging towards muscle preservation, because that is an important factor in neck pain. So especially the muscles which have to be preserved on the C2 spinous process are very important. Again, there are multiple variations in these options, especially coming from the Japanese literature, and these are the guys who are experts in laminoplasty. So what is the difference? So we've gone through the literature and meta-analysis of all studies, wherein there's no significant advantage of one procedure over the other. However, the open door laminoplasty has a better post-operative JO score than the closed door, or than the French door. And it also has got a better canal expansion. However, in terms of operative time, blood loss, complication rate, C5 palsy, which is an important complication, and loss of range of motion, all these factors are more or less same. So now we come to what are the issues. The two most important issues are neck pain because of dissection of the muscles and C5 root palsy. Now this is again a different topic altogether. Neck pain, there are multiple theories which are advocated. The significant points are preoperative JOA scores. The patients who have got preoperative neck pain are not the candidates for a laminoplasty, and you need to think of other options like a fusion surgery. Also, functional scores, whether the patient has got radicular symptoms or myelopathy symptoms, are important. Alignment of the cervical spine, as in all posterior procedures, it has to be lordotic so that the cord can fall back. Depends on what type of laminoplasty you are doing. If it's a muscle preserving laminoplasty, like you do a preservation of muscles on the C2 lamina, so-called dome laminoplasty, then the incidence of neck pain is much less. So now the pendulum is shifting towards the more minimally invasive methods, which probably has a role in less neck pain post-laminectomy. Now this is one of the most important issues. There's no paper which says or which mentions, which doesn't mention C5 palsy in cases where the patient has gone a posterior decompression procedure. So if you can see, there are 100 papers which we have analyzed, studies, and 90% of the papers report the incidence of a C5 palsy. So it's pretty much common. It is said that if you haven't had a C5 palsy in a posterior decompression procedure, you haven't done enough procedures yourself. So the incidence can vary from 3% to almost as high as 20%. In some cases, they range to around 30%. So what is the mechanism? So there are multiple theories, and whenever there are multiple theories, that means there's no single cause which can be pinpointed. So it could be iatrogenic. Some say it's a reperfusion injury. Suddenly the cord swells up after long-standing compression. It can be because of the cord fallback and the C5 nerve root is still entangled in the foramen, and so it gets stretched. Also, the C5 is the apex of the cervical lordosis, and hence it doesn't allow too much of a cord for nerve root fallback, and that can be a cause, and in direct cases. Also, there's no clear-cut definition of C5 palsy in the literature. Some studies say that it could be motor deficit, some combine it with biceps deficit, some combine with sensory involvement. So there's a lot of confusion in the literature regarding the C5 root palsy. So one thing is sure, that patients who have significant anterior compression, when we talk of posterior decompression procedures, we are basically taking into account only the posterior compression. But when the patient has got significant anterior compression, that means there's a significant canal occupancy ratio is more than 50%. These patients are more prone for C5 palsy post-operatively, where the incidence can triple. So here is one paper where when the occupancy ratio is less than 50%, it is almost 5%. It shoots up to 16.3% whenever the occupancy ratio is more than 50%. So that gets us to the next question. Does foraminotomy help? Now here I would like to add to the confusion rather than clearing it out, because logic tells us that yes, if the C5 root is getting trapped in the foramen, then you need to release it. However, and there are multiple papers which are suggesting that yes, C5 palsy can be, the incidence can be reduced by foramenotomies. Some people do a prophylactic bilateral foramenotomies. However, patients who have undergone a foramenotomy, there's an incidence of C5 palsy post foramenotomy also. So again, we are not sure as to whether the foramenotomy really works in these cases or not. Two most important factors which need to be taken into consideration is the duration of symptoms, and this is something that I noticed when most of the panelists opted to not opt for surgery in the previous cases. So cord intensity changes are important predictors of a post-operative C5 palsy and also the duration of symptoms of these patients. So to conclude, basically it's a simple posterior decompression procedure where we can have best of both the worlds, good decompression and motion. The indications are limited where we need to be sure that at the end of the procedure there's no residual anterior compression which is remaining. When executed properly in a demanding technique, it gives good clinico-radiological outcome and an excellent functional result. However, most of these patients, especially in posterior decompression procedures, need a good amount of counseling. More than the recovery of deficit, I think it's important to sit down with the patient, and it is always counseling. For me, I have had 3 C5 root palsies, and most of these patients do recover, but take a long time and it's a nightmare for you. So more than the recovery of deficits, it's about counseling, and you may lose out on a few patients, but that's okay. So that is regarding laminoplasty and C5 root palsy. Thank you very much.